Hello, I'm Mark Erickson. I'm a professor of orthopedic surgery at the University of Colorado with a subspecialty interest in pediatric spine deformity and pediatric orthopedic surgery at Children's Hospital Colorado. We're here today to discuss my interest in the innovations and new techniques in research associated with pediatric spine deformity that we're doing now at Children's Hospital Colorado. Let me start by giving you some of my philosophy on learning curves. As an academician working in an academic institution for now more than 20 years, I firmly believe that learning curves are perpetual. And as a surgeon, if I feel like I've dropped off a learning curve or stopped trying to get better, that I'm doing a disservice to my patients, the population, our residents and fellows. And as an educator, I pride myself on trying to continually improve upon the techniques that we do, which is why we're here talking today about innovative techniques in pediatric spine deformity. As far as my personal quest in using robotics as a new innovation and a new technology for spine deformity surgery in children and young adults, that curve is very interesting. There's a very small number of us that are doing pediatric spine deformity with robotic assistance in the United States. We're constantly collaborating with each other to figure out the best ways to improve upon our learning curve and our workflows as we do these complicated surgeries. I feel like we've gone through the first hurdles for sure, and now are learning more things that can help fine-tune and make it an even better technology. So I think we're past the first initial curve where everything seems to take a lot longer, and we're working through those. We've worked through those frustrations. There's some unique things that are necessary in robotics with children. The kids being smaller and their spines being smaller, the tools, the instruments, the implants, the things we use are being fine-tuned to make it safe to use in kids. And so it's a very exciting time. One of the main challenges that we work on is we need the spine to remain still or not move while we're using robotics. Robotic technology assumes that the information you input into the robot remains constant. So said succinctly, what we need to do is the patient's in the prone position laying on their belly while we're doing their spine surgery. We need that spine segment that we're going to use the robot for to remain still and not move so that the robot can be maximal in its accuracy. And so techniques and workflows that we do to do that are such that we need to stabilize the spine in ways so that it doesn't move. While we're doing that, and attaching the robot to the spine is a big factor in accomplishing that. So we need to have the robot be attached to the spine and the spine remain still. That's one of the main workflows that we've been working on now. I'm a big believer in team concepts. Having worked through many opportunities to build teams, I've had the great fortune of having an incredible team to work with at Children's Hospital Colorado in establishing not just for robotics, but complicated spine surgery in general. And so I think one of the key components is having a consistent group of people that are interested in the same outcome. So in robotics, for example, I need to have the robot specialists. I need to have surgical technicians and nurses in the operating room that use the robot and are able to then become facile with the nuances of how we do the robotics portion of the procedure, but also the spine surgery itself, not just the robotic aspects. And then I have the great fortune of having a physician's assistant that I've worked with we've been together for more than 1,000 spine surgeries, doing the surgeries together. So we know where we need to go with each case, and then we debrief after each case to see what we need to do differently. Not just robotic cases, but all of our cases. That's how we establish our team. And then that allows us to bring in innovative technologies together. And as the team is all about the innovation and what we're trying to do, then the team will accomplish that, much like teams in team sport and other things that we do in life. So the team concept is pivotal for this to be successful. What specific areas of pediatric spine deformity can robotics help facilitate and make a better outcome? That is a great question, and one of my main reasons for interest in robotic technology as it applies to pediatric spine deformity. The reason why is there are certain deformities that occur in children where we need to use fixation, which is a term we use to describe hooks and rods and screws, how we attach to the spine in children and in adults. And there's certain deformities and instabilities that occur in very complicated areas of the spine, the cervical spine, the thoracic spine, and the lumbar spine, where we need to place attachments. And previously, we didn't have access to things like screw fixation in very tiny vertebrae with very small pedicles. The pedicle is an area of the spine that we use predominantly for fixation with screws. The robotic-assisted accuracy allows us to put very large screws or appropriate size screws into pedicles that are small. For example, many pedicles in the upper thoracic spine in children can range from 3.5 to 4.5, maybe 5 millimeters in diameter. To be able to put a drill that's 3 millimeters in diameter into a pedicle that's 4.5 millimeters in diameter requires an extreme amount of precision. The benefit of having that is it's a much stronger method of fixation. So if we can get the fixation in there safely, which robotics adds to the safety by the accuracy and the precision, that affords us to create an opportunity to help facilitate the stabilization of these deformities and trauma in children that are very small that otherwise we might have had to use other methods of fixation. Sure, as far as the adjustments that need to be made in the robotic technology to afford the opportunity to maximize their impact on children and young adults with spine deformities, there are a few of those. The two biggest ones that we're working on right now is size. And by size, I mean the implants, the drills, the screws, the attachments that the robot helps us put the implants in place with safely and accurately are designed for adult size bodies. And when you have children, under 10 years of age in particular, but even up to 12 years of age and 13 years of age, their bodies are much smaller, and the anatomic components where we put these screws and hooks is also much smaller. So we need to have smaller tools that work with the robot in order to facilitate that. So those are in development as we speak. Another area that I would say is of paramount importance is movement. And so when we're doing 1 and 2 level, like an L3-4 or an L4-5 surgery for an adult with degenerative disease, for example, you have 2 segments that you need to have not move. And so the movement is critical because if it moves, the robotic accuracy goes down. So we're doing surgery over 12 and 14 spine segments at times in these spine deformities in children. And when we do that, we need to make sure that all 12 of those segments remain still and constant while the robot is assisting us in facilitating the accuracy of the screw placement. If it moves, that alters the accuracy. So those 2 big areas, the size of the instruments and tools that we use with the robot, as well as the movement issue, are the 2 biggest issues that I think are specific to this population. The basic fundamentals of how the robotic system works, I call it a cobot, meaning it's not robotics where I sit here in this room and the surgery is being done in another room by the robot. That's not the case at all. What I mean by cobots is we take our information, anatomic information as I describe it, usually in the form of a CAT scan. We do it with an intraoperative scan that we take while the patient's asleep and already in the prone position. We take that information, that anatomic information of the bony anatomy in the area that we're going to do our surgery, and transfer that information into the robotic computer. So then the robot knows where the anatomy is at that time while the robot's being attached physically to the spine of the patient or the bone structure of the patient. The robot can then move to the segments as we go through what we call a process scan and plan. So we do our scan that we just described, introduce it into the robot, and then we plan the strategy for the surgery live in the operating room. For a segment of 16 inches worth of information, the planning session takes about, at this point in our learning curve, about 15 minutes to plan the screws across that segment. We plan the screw length, the screw width, the trajectory, the portion of the bone that's going to be involved, and we do that all on the robotic computer. Once that's set, then we have an agreement with the robot, meaning mentally, agreement with our technology and our brains as well, of what lumbar 4 is, for example. And then we send the robot to the level that we're going to work on, and the robot then will move, the robotic arm will move to that segment at the trajectory that we have chosen in our scanning and planning. The reason I use that term cobot is that a robot can help facilitate accuracy and can facilitate the precision with the surgery is performed. Said succinctly, robotic surgery and technology, I feel, has a very strong opportunity to make highly competent, technically excellent surgeons safer, more accurate, and more effective in the surgeries that they're performing. It cannot take a surgeon that doesn't have those competencies or technical skills and make them competent or technically better. That's the differential line from my perspective. So I think cobotic surgery is something that helps us facilitate the accuracy and placement, especially in a center where I do lots of teaching and instructing younger surgeons on how to perform surgery safely. I feel like the robot is an extra additional layer of safety to allow me the opportunity to teach others how to do this safely and help us facilitate the improvement of the care of these patients on an ongoing basis. We'll probably know more years to come, but I think what we can hopefully help, I think part of the learning curve, which was an earlier question, is in doing this kind of work in an academic center where we are, our goals are, we want the next level to be that the people, when they start off robotics, it only takes 10 cases or 20 cases. The term bending the curve, we want to bend that curve down so that it doesn't take as long to gain the progress where we have come so far. That's true with any innovation as it works through. And so this specifically is something that, so I think in that regard, introducing the concept of robotics, because there still are many places where there's lots of questions, well, could you do this safely in other centers? I think yes is the answer, but you need to have a set of guidelines to help figure out what you need to do to facilitate it so that it can be safe when you introduce it in other places. At Children's Hospital of Colorado, we've had the robotic surgery process, and we've been working on it diligently to enhance the ability to do this surgery safely. We're collaborating with other institutions in the United States. There are 3 other institutions that we're working with very closely, 1 adult institution and 2 pediatric institutions, to try to accomplish that in all other centers so that we can then disperse this technology out to the masses and have it be safe for all to use. I mean, anytime you're looking at an innovation to bring into a surgical field, for example, one of the primary drivers, hopefully, is always to say, how can we do what we're doing currently better? And is there a way to do that? You need to have checks and balances to know when it isn't better. And so that's the principle of researching it and doing multi-center research and doing research in our own center as well to measure against the already established standards. So I think in the future, we're going to be able to do more and more work with robotics. I don't think it will be limited to the spine, for example. I think we'll be able to do pelvis work, and we'll be able to do other bone structure work more accurately and precisely as well. Tumor resection is another example where we need to have the precision to know exactly how much bone we need to remove to get the entire tumor resected. So I think there's lots of opportunity in that area. When you're working with innovation, wherever the innovation curve is, you need to be able to manage your frustrations that are associated with any kind of innovation curve. And by managing that, I hearken back to one of your previous questions about your team. I think the team needs to be bought into the process. Not only bought in, but the true function of the team is to call out when we don't think it's working well or when we think we need to make adjustments. And sometimes that's in the middle of surgeries, and sometimes that's in the middle of decisions that you need to do. And I think the true evidence of the team concept is that you need to have everybody be able to speak up. And I think anytime you're trying to take on a new innovation, it's not just let's bring in the robot and it's going to make us better. That's what I mean by cobot. The robot needs this. If you're using robotic innovation, the robot needs to fit into your team concept of how you do spine surgery at your institution. And then you then subsequently figure that out. You'll find things along the way that may have been deficiencies in your team that you thought were okay. Nothing highlights that better than having the stresses of a new innovation be brought to the table, which is a good thing if you think about it from the way I approach it, which is, well, we needed to fix all of those components anyway to make our product better and how we manage and take care of patients in our process. Robotics is just another tool that's currently available and very exciting in that regard. In regards to how should you manage the next steps if you're looking towards robotics innovation to bring into your pediatric spine deformity practice, I would suggest reaching out to the centers where this is already being done, like in most instances, and figure out what they've learned in their particular learning curve and how you might be able to attack that and address it. That's how we take learning curves and bend them down so that it doesn't take as long for the next center to ramp up for that situation. So I think that would be my best advice, is to reach out. It's a very collegial community in that regard, to figure out how to establish a robotics program if that's something you're interested in your center. And we can accommodate that and figure out how to discuss things, and then join in our pool of figuring out how to do this better and manage our patients as safely as possible. In closing, one of the things that I'd like to leave in this interview is, I think you can tell that we're very passionate about our innovation and our ability to use robotics as a method of innovating surgical treatment for children and young adults with spinal deformities and complex spine situations. If you feel like this is something that you would be interested in discussing, we would be more than happy and in fact energized to talk to you and see what your ideas would be, and to try to help facilitate bending that curve down for your institution if that's something that you would be interested in doing. So please feel free to reach out, and we're more than open to entertaining discussions in this regard.